Cention N. The name comes from the Latin word centum, 100, and ion, ion. Ion release. You will see it later. Now, we have a look at this pyramid, positioning of the filling materials. On the top, we have the adhesive technology we developed in Zurich, Switzerland in the 70s. Layering technique, horizontal layering, vertical layering, all these things. Aesthetic and high grade. This is on the top of the pyramid. But this is not the topic I want to tell you. I don't want to discuss the top of the pyramid. I want to discuss conventional technique, quick and easy, where we have glass ionomercements and amalgam. And Ivoclar has a lot of material on the top of the pyramid. But these materials, you know, these are expensive materials. Not every patient can afford it, and not every dentist can handle it. That's the point. Now, this new material, for me, it is a new basic filling material. It can be also an alternative to amalgam, but it's a new basic filling material. So, Cention N, 100, you remember, stands for 100% volume replacement. It will mean, when I have a cavity, I can fill the whole cavity with one portion in one time. No layering necessary. Absolutely not. Then, I have more than 100 megapascal flexural strength. And you know, according to the ISO standards, you need for the posterior region at least 70 megapascal. Otherwise, the material is not resistant enough in the posterior region. And then, you will see it later, it looks really nice. It's a lifelike appearance. Minamata Convention. I think you are familiar also with these things. Minamata is coming originally from UNEP, United Nations Environmental Program. And the idea is clear prevention and point 2, minimizing the use of amalgam because of the mercury. Then promoting the use of best environmental practice, usage of amalgam separator. For example, when I want to open a clinic in Europe, or in Switzerland, Austria, and Germany, I cannot buy a dental equipment without an amalgam separator. This all is absolutely mandatory to have it. And even if I'm not doing amalgam restorations, just drilling out the amalgam restorations, I need it. So I think it's not the time to discuss around mercury. You know, mercury is a heavy metal, and the problem is, on one side, can have an impact to the health, to the oral health. On the other side, much more, I would say, is the environmental impact. And in some countries in Europe, Norwegian, Sweden, Denmark, it is absolutely forbidden. You cannot place anymore. For example, in Switzerland, it is allowed to do, if you want as dentist, but just in patients not below 12 years. And not in pregnant women. This is absolutely forbidden. And the tendency is absolutely that amalgam in Europe will disappear more and more. So, you know, until now, 120 countries have signed this convention of Minamata, but the ratification, that's another point. Now the question is, are we ready for amalgam phase down? It will mean, do we have really a material which could replace this amalgam? I go back again to this pyramid. For me, the most important factor at the bottom of the pyramid is the price. is the price. Pricing. When the price is equal or comparable to glass ionomer cement and amalgam, then we can use it for this indication. Otherwise, we are at the upper level on aesthetic and high grade if it's too expensive. So this was the idea of Ivoclar, to develop a material really comparable, also including the pricing. Now, shortly, into which materials category does Cention N fall? Now, at the university, I can explain a little bit more. You are familiar with composite types. Every company was developing different composite materials. Some remained, others disappeared. We have modified composite materials, hybrid, nano, Masir, all these things. The new material, Cention N, we call it alkazide, a new type of material. It is self-curing, chemical curing, and the name alkazide comes from a special filler inside the alkaline filler. And it is quick and easy to do. 100% volume replacement, as I told you. I can replace a full volume. And so I have a clear indication for class 1 and class 2. It is unrestricted indication, self-curing and a reduced application procedure. So it is an alternative basic filling material. Now, the clinical application is simple. It is not necessary to change the preparation method because we need retention, slight retention, not too much. You know, nowadays, the times of black, extension for prevention, we don't cut away nowadays so much material. So we take out what is necessary. So if you have a small retention, just 5 degrees from the vertical axis, this is enough. This is enough. But we need retention, like amalgam. We need some retention. This is the first point we are responsible when we are doing these restorations. The minimal depth is about 1.5 millimeter. This is especially for children. That's why I mention this. This is always a question arising. And it's depending on the occlusion. But then, okay, we have 2 bottles. We have the bottle of the powder and bottle of the liquid. And we are mixing this in ratio 1:1. 1 scoop of powder and 1 drop of the liquid. And then we have a mixing time of 45 seconds until 1 minute. And then we place it directly in the cavity. No lining in the cavity, nothing. No acid edge technique, nothing. Just we place it. We adapt it. We have for the adaptation, we have around 2 minutes 30. And after 4 till 5 minutes, this is depending on the situation. Here we have air conditioning. But you know there are also clinics and practices. There is no air conditioning, so it goes faster. And after this 4 to 5 minutes, the polymerization is completely finished from the top until the bottom. This is self-curing. This is self-curing. Clinical application, we only have 4 working steps. Dose, mix, fill, and finish. And it's just finishing, it's no polishing. It will mean adjustment of the centric occlusion, of the lateral movements, nothing more. When you compare it to a glass ionomer cement, you have around 11 steps. At the end, you have a varnish coating. Cention N, only 4 steps. It is a reduced procedure. And remember also amalgam. You cannot applicate amalgam in one portion. First, second. I remember very well, and you too. We have been instructed also at the university, but nowadays the Swiss universities, Zurich, Bern, Basel, and Geneva, is not teaching anymore amalgam restorations. Just theory, but no practical. so that the students have an idea how it functions, but no courses. Cention N, only these 4. Okay, now the magic thing is this alkaline glass filler. This has been specially invented and patented by med.dent. Now, the core is silicium oxide, and the used salts around are calcium fluoride, calcium oxide, and sodium oxide. Now, in the oral cavity, you have an acidic situation. When you have a lot of plaque bacteria, sugar intake, then you have production of lactic acid, and then we have a dissolution of the ions, fluoride, calcium, and hydroxide. Fluoride you have also from the glass ionomer cements, calcium also, but you do not have hydroxide ions from glass ionomer cements. And hydroxide ions are for the neutralization. Again, normally I have a neutral pH value in the oral cavity, about 6.8, around 7, okay? Then, under an acidic attack, when we have a lot of plaque biofilm, then I have more release. This is ion release on demand. You see the protons together with the hydroxide. This makes neutralization, water. It's very simple. And it is no fake. We can prove it, and I can show it later. We developed, 35 years ago at my university, a method to measure directly in the mouth of the patient the pH calcium fluoride. We can prove this. So, you know the fluoride and calcium ions together with the phosphate from the saliva. On one hand, I have calcium fluoride, calcium phosphate, and this is strengthening the appetite. That's clear, it's old things. And on the other hand, we also position the base for the remineralisation. So, long-term performance, we can also prove this. Fluoride release and calcium release. And we have a constant ion release for 26 months. And we have especially an increased ion release at low pH. At low pH, you see this in red. We have much more than on blue when we have a phosphate buffer solution which goes to direction of the alkaline side. So this is really ion release on demand. The ion release effect regulates the pH value during the acid attack. Then it can help to prevent the demineralization. On the other hand, fluoride and calcium also are preventing the demineralization, and we are setting the base for the remineralization. Okay, 100% lifelike appearance. It looks natural. Look at this lab teeth. The left-hand side, this is Cention N, Fuji9, catechmolar. It's opaque, it's not living. So, I'm showing you a small clinic video how this is done. This is including audio.
After you have placed an Optrogate lip and cheek retractor, remove the defective amalgam filling.
Okay.
The cavity should provide adequate retention. As you will not be using an adhesive, you should not bevel the enamel edges. Carefully secure the partial matrix in place using wedges. Establish a dry working field. If necessary, use a saliva ejector or cotton rolls to do so. Hold the bottle containing the liquid in a vertical position. Squeeze the bottle lightly and evenly to dispense 1 drop. Make sure that the drop separates from the bottle by itself without touching the mixing pad. This helps you prevent air bubbles from becoming enclosed in the liquid. After use, close the bottle tightly. Shake the bottle containing the powder before use, and then remove the required quantity using the measuring spoon. Wipe off excess powder at the plastic insert of the bottleneck, and place the material on a mixing pad or glass plate. The mixing ratio of the powder and liquid is 1 measuring spoon of powder to 1 drop of liquid. If you restore a large cavity, adjust the mixing ratio using 2 measuring spoons of powder and 2 drops of liquid, or 3 measuring spoons of powder to 3 drops of liquid. Close the bottle tightly after use. Mix the powder and liquid using a plastic spatula until you have reached a homogeneous mixture. You may apply as much Cention N as you see fit. Carefully pack the material into the cavity. Given its self-curing properties, the material can be applied in any layer thickness. Remove occlusal excess material. The working time is 2 minutes and 30 seconds. Once the setting time of 4 minutes for the self-curing mode is reached, remove the matrix and wooden wedges. Check the occlusion and adjust as necessary. Remove excess material using suitable tungsten carbide burrs or fine-grained diamonds and adapt the margins. Use diamonds, tungsten carbide finishers, or flexible finishing discs to remove excess in the proximal area. High-gloss polishing is not necessary. The tooth is now restored to its function and tooth-colored appearance. As can be seen at the recall after 1 week, the restoration blends in well with the rest of the dentition.
Okay. I think you could easily see that it is much more aesthetic than amalgam and even glass enamel cement. 100% lifelike appearance. Flexural strength. You know, we cannot measure it. As dentists, at the patient, we cannot measure it. You just can measure it at the research departments, universities, in the labs. What will mean for the clinician flexural strength? It is just the resistance to fracture, nothing more. And so, when these measurements were done, we could easily see that Cention N has more than 100, and glass enamel cements like Fuji 9 are in the 20s. This is the difference. And this is an interesting study. It's been done by the University of Amsterdam. Clinical failure of class 2 restorations over a 6-year period. And you see, always you have this typical chipping of the marginal ridge. It will not break at the isthmus. And this fracture will arrive about 6 until 8 months after placement. Okay, it's depending on the occlusion, it's depending on the cavity. But for the posterior region, it is really not suitable. For posteriors, premolars, molars, it's not suitable. And you know, the patients are also not happy with us because food impaction, whatever are you eating? Fish and meat and salad and all this thing, yeah, is sticking. Food impaction. And then, let me tell you, as periodontist, I started my career in periodontology in Zurich, you know. You have inflammation, disappearing of the papilla, formation of pockets, and then you have the periodontal case. It's easy to explain. And so I think we dentists, we have also the responsibility to create nice interproximal contact points. Some economic considerations. With this system kit, I can do more than 100 single tooth restorations. Exactly, they calculated 167, but okay, this is depending if you have a premolar or a large molar, class 2. For me, more than 100 you can do with such a kit, you know, more than 100. Also volume comparison, because this is also necessary and this is important to compare with amalgam. With 2 scoops of Cention N, the second line is more efficient regarding the volume than a 3-spill amalgam. You see the 3-spill amalgam has only 0.17, and with 2 scoops, I have with Cention N, I have 0.19. So these are considerations we really have to look at. So we have these 3 points. The flexural strength is enough, more than 100. Then it looks nice, and we have this ion release. This makes the difference. Material basics. I think we have to explain something. In this powder bottle, we have all the fillers inside. Especially this patented alkaline glass filler for the ion release. Then we have other fillers, well known. We have ytterbium trifluoride, the best filler for the radiopacity. Then we have some filler newly developed for the as shrinkage stress reliever and some initiators. Then the liquid bottle. The liquid bottle, we have dimetacrylates, but it's a new type of dimetacrylate. It is not anymore bis-GMA, not anymore. You know, bis-GMA has some influence on health for women and men. There are studies because it is similar and related to some hormones. So the tendency is really to replace more and more this bis-GMA. So Cention N has new type. And now one thing is new for you. We have a photo initiator additionally in this powder bottle. So I told you, basically the material is self-curing, auto-curing, self-curing. But if the dentist has a light equipment, he can use it. But you should not forget, also in your country, there are a lot of dentists, they do not have a light equipment. They don't have. Or they have a very cheap one which is not functioning. So we have the possibility, you know, optionally you could use also a light curing. Altogether we have 5 types of fillers. The particle size is between 0.1 and 35 microns. You see these 5 types. So this one is well-known, barium standard filler, ytterbium trifluoride, has been invented by Ivo Clark 25 years ago. It is really the best filler to represent the radiopacity. Then we have the isofiller. It is a pre-polymerized filler. This is really responsible for lower shrinkage. We have a shrinkage of this material of only 2.6% by volume. So it will mean it is really below 3%, and this is very good. Then calcium barium, fluorosilicate glass, also well known. And at the end, our famous alkaline glass filler. Cention N contains is highly loaded. It's really highly loaded, 78% by weight. So it will mean it is strong enough, resistant enough to the forces in the posterior region. Storage stability. I told you, the material has been developed for every country. Now you still have here wonderful 24 degrees, 25 degrees. Now in Europe, Switzerland, we have minus degrees. In Africa, they are starting up again to 30 degrees. So the range will continuously recorded by the company between 2 and 28 degrees you should store the material. And we have now results over 3 years. In vitro results. We check the flexural strength. I told you we cannot measure this at the clinic in the patient. The idea is with this bar, you know, with the force, and then you see again much more than 100 compared to glass ionomer. Then, flexural strength versus compressive strength. That's another point. So this is the type of compressive strength, and you see also that we have wonderful data for Cention N compared to glass ionomer. So you see where it is loss of substance for us. loss of substance, like a car tire. You lose some material. And you see, red is ceramic, the antagonist. Because it is ceramic, it is very hard, it's very strong. But you see, we have some loss of substance with Cention N, it's okay, but not so much like glass ionomer cements. And we checked also the wear of Cention N versus glass ionomer cement. Glass ionomer cement is blue, red is Cention N, and green is Z100, Z350 from 3M, a composite material. So you see, Cention N, this material is really lying in the range of a composite material. Absorption, solubility, everything has been measured according to the ISO standards 4049. So this is nothing new. I think I don't want to go in more details. This is not necessary. So you have summarizing all these things again: transparency, amalgam, glass ionomer cement, Cention N, compressive strengths. You see compressive strengths, amalgam we have 300, and we have also around 300 for Cention N. In vivo results. We have now about 5 studies running around the world. The first study we started in Turkey, University of Istanbul, together with University of Zurich. And this was Cention N in class 1, class 2 cavities in permanent teeth up to 3 years. And I show you the 1-year results. We have now, end of December, the 2-year results, but they look the same. I could see it 2 weeks ago. So we had 64 restorations we could follow up, and we didn't have debondings, no fractures, no cases of secondary caries or endodontic complications. And additionally, the patients had to fill out a questionnaire if they were satisfied or not, and 98% were happy with the restorations. Then, we have a similar study in the States, University of Alabama, Birmingham, and this is interesting. In the same patient, we have Cention N with adhesive, without adhesive, and in the same patient, amalgam restoration. So, also class 1, class 2, and the results are of 1 year are as follows. We had 38 patients and 115 restorations. So we didn't see a difference between Cention N with adhesive and without adhesive. No difference. And additionally, in general, the Cention N results were similar to those with amalgam. This is really exciting. Then we have a similar study now in Malaysia and Cambodia. So you see you see the columns really. Only the difference is here. You see different columns, but this is the luster. Amalgam you can polish to luster. Cention N is no luster-like. That's why this is different. And all the other things are similar. Let me go towards the end, go back to the 70s when we started in Europe and Switzerland. I was among the first dentists who did in the posterior region composite materials. And at this time, we didn't have etching of enamel, no bonding. We just had phosphate cement as liner, nothing more. And this was adaptic and concise, 2 pastes, mixing 1-to-1. Then also volume replacement. The whole stuff you applicated in the cavity. Sometimes digital impression, without gloves at this time. Digital impression. Don't forget, I have 37 degrees. Accelerates the polymerization. It was working, okay? And almost no pain after treatment. Why? Nowadays we are doing adhesive restoration technique. That's wonderful. If you are doing this perfectly, it will mean perfect application of the acid, rinsing out correctly, drying the cavity, not over drying, all the steps accordingly, then you are successful. You know this. But we always see a lot of also outside. You know, at the university, everything is working. But outside in the countries, they are doing very fast, and then they always have post-operative things because over-drying the cavity or not properly applicating the bond. And with these cases, we didn't remove the smear layer. Also with Cention N, we don't touch the smear layer. We can touch with the adhesive technology, but must be correctly. Then you are successful. That's the difference. I show you this case. I did this in 75 with adaptic. And 10 years later, I took this picture. What you see? Discoloration. That's clear, because the gaps were 100 and more. The gaps of the marginal adaptation. And my patients were also smoking or taking coffee and tea. We have discoloration. And you see the wear. But this, 10 years in place, it's not bad. But there is wear. But okay, this was the first generation of fillers, big rocks falling out after some years, and first generation of dimetacrylates, the first generation. This was 35 years ago. Do marginal gaps lead to marginal discolorations? There are studies of Heinze and so on. That's clear. Marginal gaps, we have more marginal discolorations depending on the oral hygiene. The other question is, do marginal gaps lead automatically to marginal caries? Also, this is depending on the oral hygiene. But if the oral hygiene is perfect or almost good, then there is no incidence of marginal caries. So some things, do fillings in bulk with Cention lead to enamel cracks? We say no. Marginal gaps lead to discoloration? Yes. Do marginal gaps lead to marginal caries? No. And is the wear of Cention N lower than of glass ionomer cement? Yes, it is lower. It's much lower. The flexural strength is higher. Okay, so at the end, some clinical cases, not too much, just to give you some ideas. Radiopacity. Look at the small amalgam restoration on the buccal side of the first molar. It appears in the bite wing again, and the other restoration, class 2, has been replaced by Cention N. So if you compare the radiopacity of amalgam with radiopacity of Cention N, I would say it's really, in the bite wing, it's absolutely sufficient what we can see. Then, again, this case you could see in the video. Don't forget, please, the proximal contact point. We have to pay attention. It's working. So this restoration, I did this for a friend of mine, his maxillofacial surgeon. He had a cancer patient. He detected a deep caries at the second molar. He told me, oh, Philipp, could you do this, please, as fast as you can? You know, it is not a high-grade restoration. I just could help him within 7 minutes to do this. You know, it's not high grade. We have to differentiate. But look, my colleague Mohan from Chennai, he did this without rubber dam, with cotton rolls. Then you see the sensitivity of this material is between amalgam and composite. You should not work underwater, not submarine working, but you see with cotton rolls, even with wet cotton rolls, it's working. He's using sectionals, and you see the result. It's okay. It's functioning. Geriatric dentistry. This will be the challenge of the future of all of us, especially of the young generation. You see, an 8-year-old patient in India, result. It's very easy to do. Then pediatric dentistry. We have also a study running in Ponta Grossa, Brazil. This has been done according to the ART technique. You are familiar with this, automatic restorative therapy. It is for me not an optimal dentistry, but better than nothing. Better than nothing, my friends. This has been done by dental students. And they didn't have a dental equipment. They just have a table, a wood table, and the children were lying there, and they did it. No suction, nothing. I could see this. It's working. So, Cambodia, we have a study running there. The caries incidence in Cambodia, this is one of the countries, I think the country with the highest caries incidence. This was a dental student, 22 years old with 30 primary lesions. 30. So I think oral hygiene is one thing. That's why we have this iron release and all this thing. So, this can also help. You see here just the type of cavity preparation. I don't want to cut away too much material. I told you 5 degrees from the vertical axis is okay, not more. Then, last case from the Philippines. Mylene Igrubai, she's member of the aesthetic dentistry board of the aesthetic dentists. She told me at first, no, I would not use this material. You know, she's working, she told me, on the top of the pyramid. No, never. Then I could, with some charming words, I could convince her to try. And then she tried it. She did it. And said, it's really, it was really only Cention N. And she told me, yeah, it's very strong. It's not bad. And she came also with the idea to use it as sandwich technique. Okay, it's not new for me, but the idea, she would like to combine. So, at the end, for me, Cention N is an open system. In the middle, I have self-curing for every dentist all over the world. Quick and easy, fast, self-curing. Okay. Then, you know, I have photo initiators inside. When you have a light equipment, you can use it. You can work faster. It's no problem. Especially in pediatric dentistry, the children don't want to stay so long in the chair. Okay, you can cure the most upper layer, 3 millimeters. It is already finished, polymerized. You can adjust the occlusion, and then the boy can go. No problem, because the other part is self-curing. Then, if you want to use acid edge or adhesive bonding techniques, you could use, no problem. It is a question of finances, you know? Just as, because you know the bonding things. This costs money, and not every dentist, not every patient can afford it. But you in the clinic, if you want to use, you could use. Then you don't have discoloration, because, you know, you don't have gaps then. You could use, you can combine. And green, you can do other classes, class 3, class 4, class 5, if you want. So for me, it's an open system. Delivery forms, I'm not salesman, I told you. Just there are a starter kit and a system kit, refillers, and only one shade, only A2. We don't need more, we don't need more. Then, if you ask the dealers what they sell mostly A2, sometimes A3. But did you ever use C or D? Sometimes B1, okay, if you want Hollywood white, but normally A2, A3 is not bad. A2 is enough, absolutely. This is really, for me, a new basic filling, a new alternative to amalgam.